Well, hello, everybody. Welcome to IRG's Health Matters. Why Do I Hurt? Again, this is a podcast that we do here at IRG Physical and Hand Therapy, where we talk about various health topics. We might talk about community health topics. We might talk about certain topics with certain disciplines, various health topics. Our goal here in our podcast is to educate you so you have increased understanding of any health topics. And today, we are so lucky. We are joined by Dr. Wes Mitchell. Dr. Mitchell, how are you? Welcome to IRG's Health Matters podcast. How are you?
I'm doing very well. Happy to be here.
You're fired up. You're just recently moved to the Northwest, the Pacific Northwest. We have a beautiful fall going on. You're working up at Everett Bone and Joint in downtown Everett. You have a significant journey. I was looking at your bio, and I always like to start out for our listeners to really get to know Dr. Wes Mitchell. Tell us, this is your life, Dr. Wes Mitchell. Tell us how it started. Tell us your journey to become a fellowship-trained hand surgeon. By the way, everybody, just real quick, hand surgeon, fellowship-trained. I got to tell you, these guys and gals, man, you talk about detail. This guy, Dr. Mitchell, I guarantee you, he's going to talk about detail today because these folks like detail. If you're a hand surgeon, you're doing tiny stuff, microscopic stuff, cool stuff. Dr. Mitchell, tell us about your journey.
Absolutely. So, yeah, I'm coming here from, I actually grew up in Texas, spent most of my life there. My parents moved there when I was pretty young and went to college at UT San Antonio, went to medical school then at UT Southwestern in Dallas, and just kind of had a passion for orthopedic surgery. I grew up actually playing music and not sports so much. And so I kind of had a little bit more interest in kind of the finer things. A lot of orthopedics involves a lot of, power tools and heavy, hammers and things like that. And that's fun too. But, I always kind of gravitated towards like kind of the smaller, fine-tuned stuff. And especially with fingers and hands, that's pretty much how you interact with most musical instruments. And so anyway, I went to residency in Houston at Baylor College of Medicine, had a great time there, and then really kind of dedicated myself to hand surgery and went out to UCLA for fellowship training in hand surgery and microsurgery as well. Like you said, we do a lot of small things in the hand, and sometimes you need the microscope to really help with that.
I'm guessing. Let's just go. Listeners, we're going to go for a guess of the instrument that Dr. Mitchell played. I'm guessing it was a clarinet. Saxophone, clarinet? No? Come on.
Nope, violin, actually.
Oh, my God. Even better. Yeah. Even better. Yeah. Some taste, some sophistication there. Yeah. That's crazy. Yeah. That's crazy. So, for our listeners, when you talk about microscopic surgery and things like that, the hand, I want everybody that's listening right now, I want to take an opportunity to look at your hands and understand the tendons, the ligaments, the nerves, the bones, the dexterity, the intricacies, the detailedness. And we all can appreciate, when our hands are working, man, they're fantastic. They're fabulous, that's our thumb opposes. That's why Jack Horner could sit in his corner, you know what I'm saying? It's amazing. Tell us about your training. I want you to get deep into your fellowship because fellowship is significant. Yeah.
No, absolutely. I worked with some amazing surgeons, kind of world-renowned surgeons at UCLA. One was Prosper Benheim, who's been there for over 25 years, is a world expert in conditions like Dupuytren's disease, where he's sort of helped to pioneer some non-invasive treatments for that. And then Cody Azari was also a huge mentor of mine, and he actually pioneered hand transplantation at UCLA. He founded that program. And so, our fellowship was just, high volume. We did a lot of surgeries, we did a lot of non-surgical treatments. Like I said, a fair number of microsurgical cases where, we're taking parts of the bone out from the leg or other parts of the body and flipping it around and shaping it and putting it into the hand, hooking up the blood vessels and the nerves and everything. I mean, it's a lot of work sometimes. You have these kind of crazy surgeries, but patients do really well. And, it's really a blessing to have worked with some of those guys out there.
So nonchalant, hooking up these blood vessels. I mean, by the way, people, those blood vessels, it's like a thread. It's like a piece of thread, right? And you're like,
oh yeah. I mean, we like to say that the suture we use is thinner than a human hair. And so you take the microscope and, it's, 40 times or, 50 times X, you're trying to piece everything together and make sure it flows. And, it's a lot of work. Like I said, I had some wonderful mentors.
Yeah, it's amazing. It's amazing. And before surgery, like you're not having 12 cups of coffee, right? Yeah.
That's true. You gotta balance it out a little bit.
Yeah. It's just amazing. I mean, it's just amazing what the advancements in medicine and technology. I've been doing this physical therapy gig for like 36 years or whatever it is, right? And who's counting when you're having so much fun, right? And, but the advancements in the technology and everything that's happening. I mean, you're talking about it. I mean, 35 years ago, I mean, if you amputated, a traumatic amputation of your finger, you're pretty much, you lost your finger, right? I mean, it was kind of, unless you got in there really quick and got in the right hands. But in today's world, with the advancements in techniques and microscopic surgery and things that you're doing, it's amazing what you all can do in the hand. And then not only you can put it back together, but you put it back together where people can function again. And it's amazing because when you lose you know how it is, you appreciate the hand more than anybody, but you lose the functionality of your hand. You lose a lot of your life. I mean, you do.
Absolutely.
Yeah.
Absolutely. 100%. Yeah. That's how you interact with the world,
Exactly.
So, being able to restore that function, with all the techniques we have, all the tools we have is just really important.
Yeah. What is the favorite part of your job? I mean, I know that's an open-ended question. It's a big question, but what do you really, you sound like you're very passionate. I mean, come on, just to study for all those years. Come on, Sophie, look at that. That's how many years of education. I mean, just to do that for all those years. I mean, you're passionate about it to start, but what do you like to do?
It's just amazing to, to work with patients kind of through certain problems and then kind of get to the other side, whether it's surgery, non-surgery treatments, whatever kind of fits their needs and their demands. And, it's just really cool to have them do well and be so grateful, like I said, to kind of return them back to what they want to do, the activities they want to do, just daily life sometimes. I mean, it's really special, kind of the effect you can have on people and some of the relationships you can build, throughout the years of your practice. Obviously, just now starting here, but it's cool to kind of see it develop over the years as people can, like I said, just kind of really, you can change their lives. It's really amazing.
Yeah, and you do everything from repetitive trauma, overuse type situations from the elbow down. That's fair to say. I mean, being fellowship trained in upper extremity, the upper extremity for you in your world is elbow down. Is that fair to say?
Yeah, in general, that's correct. I mean, every now and then I'll see a patient for, something that kind of blends into the shoulder. I mean, as you know, the full upper extremity, a lot of things kind of crossing joints and, but I tend to stick more kind of elbow down, especially like forearm, wrist. But yeah, I mean, I think that's pretty much how I think about it. And then I think fellowship training really does add another level just because, orthopedic training, you're learning everything, spine, joint replacements, all of that. So I had maybe 6 months total of like a focused hand training over 5 years, which, obviously some of that you're kind of forgetting and then remembering and forgetting and remembering, but, a solid year of hand surgery, just every day focus, you learn so much more in that year than, everything else put together. So it definitely makes a difference.
I mean, for our listeners out there, when you talk about a fellowship, what Dr. Mitchell is talking about, and he just indicated it's 12 months. It's 1 year of very intensive, almost all hand surgery, right? That's really what you're doing.
Absolutely.
You're really working. So you're doing what? I mean, I bet in a year, I'm just going to guess, you probably know this number, but I'm going to guess, we're going to play a little game. I'm guessing you probably did 700 cases of hand surgery in a year of various cases.
Yep. It was pretty close. I think it was more like 850 cases.
I knew you'd know. I knew you'd know.
It was, yeah. We have to keep track, believe it or not. But
that's
partially
great.
For my own, partially for my own curiosity, and then partially just to report it. So obviously all the fellowships sort of have to report to the same sort of governing body. But over 800 surgeries, and that doesn't count all the other non-surgical procedures I did.
Just the clinical time.
A lot of the. Yeah, exactly. I mean, it's just almost every patient interaction. You're doing injections, or you're doing, like I said, some of the non-invasive stuff for Dupuytren's, for instance. It's just lots and lots of experience.
For our listeners, so you work. I mean, your schedule as a surgeon, as an orthopedic surgeon, I mean, you're doing clinical hours, and that's where you're going to have patients coming in, and they might be post-op or pre-op, or they might just come in because they have an overuse, and it's an evaluation. You might do some treatment in the office and stuff like that. What is the day in the life of Dr. Wes Mitchell now that you're living in the beautiful Pacific Northwest? I'm sure you're carving out time to snow ski and hike and all that stuff.
Oh, absolutely.
Yeah.
I mean, the nature here is just incredible, especially compared to Texas. I mean, no shade to Texas, but we're just astounded by the mountains every day, looking out and seeing Mount Baker and
oh my God,
Peak and all that.
Yeah,
incredible. But Yeah, so I do clinic pretty much every day during the week, and they're still working me into the regular schedule. Obviously, one of my partners, Dr. Havener, is kind of phasing out and getting ready for his retirement, for which he's very excited. So I'll take over his surgery time on Wednesdays. But yeah, I see patients in the afternoon, patients in the morning, and then I'm kind of getting familiar with the community, going out to start to visit some sites, do some meet and greets here and there in the coming weeks. And then I also take call at the hospital at Providence. So
Yep.
I'm on call for hand related complaints as well as general orthopedic stuff. And yeah.
Oh, wow. Interesting. Let's talk about Quervain's Tenosynovitis. I mean,
Yeah.
that's an area that we talk about. That's a big word for an injury overuse. Tell us what's going on there in Quervain's. Let's just say Quervain's. Let's tell us what's going on there.
There you go. So I like to say Quervain's. I don't know if there's a right or a wrong way to do it, but
You're probably right. After 850 cases, you're right. I've always called it. Yeah. Okay.
Who knows? Some guy in the 1800s,
Yeah.
But anyway, super common condition. It's wrist pain, kind of on the thumb side of the wrist, just around the base of the thumb. And it's basically you have two tendons, the APL and the EPB. They're two tendons that start on the elbow and they kind of come down the wrist, and they actually attach to the base of the thumb, sort of the metacarpal, as you will. And essentially, they run in a tight tunnel, kind of right over the top of the radius bone as it kind of becomes the joint. And that tunnel is really, really tight. It's bone on three sides, and then on the top, it's this, thick, basically ligament almost. And so for whatever reason, we don't really know exactly why, but, a lot of times it's overuse related. But people can get inflammation of those tendons. And because it's a closed space, there's only so much room for those tendons to expand. People get a lot of pain there, and sometimes your thumb can almost lock up a little bit occasionally. And so, like I said, super common. You have pain in the radial side of the wrist, and it is a lot worse with thumb motion.
Yeah, and the positive sign for that, you're talking to a physical therapist here, but I can still tell you the positive sign. It's called the Finkelstein sign.
That's exactly right.
Yeah, from a guy, Finkelstein invented this technique, and you can move your wrist. It stretches those tendons, and it reproduces the symptoms. So it's a soft tissue kind of overuse, repetitive trauma. You might see this in someone that maybe is playing the violin, over playing the violin.
Absolutely.
Someone that's working. Maybe you change jobs, or you're doing something repetitively with your thumb. And the thumb activity,
100%.
And just creates that.
100%.
And besides the Finkelstein sign that you're going to do, the patient's not going to come in and show you, I got a Finkelstein sign. You wish they did, though, didn't you?
I know, right? Make my job easier for sure.
What kind of symptoms would someone be having at home and with activity? I mean, this comes on a little bit with activity, and let's talk about signs and symptoms and kind of what they might be experiencing.
Yeah, absolutely. So a lot of times people get burning, kind of almost like a sharp burn sensation, kind of like I said, right at the base of the thumb area, kind of the radial styloid area. A lot of times this works with thumb motion. So any kind of thumb maneuvers, whether it be, I don't know, typing, texting, tight grip, trying to get, caps off of bottles, that kind of thing. That's kind of, and there's wrist motion associated with it too. Like you said, the Finkelstein maneuver is actually a thumb and wrist kind of thing. So, ulnar deviation of the wrist is also going to exacerbate that. There's actually association with nursing mothers as well. I think people, we're kind of holding the head of an infant, your thumb is sort of abducted or, out from the body, and your wrist is ulnarly deviated. So there's actually, we see a lot of this in kind of younger women, nursing mothers, that kind of thing.
Yeah, it's interesting. So this person is going to experience these signs and symptoms, and then they're going to seek attention. They're going to come to you. And if I walk through your door right now and had those signs and symptoms, what would be, obviously you're going to do a history physical, you're going to exam, but tell me about the treatment course real quick. For all of our listeners, I just want to update everybody. We are talking to Dr. Wes Mitchell. Dr. Mitchell is a fellowship-trained hand surgeon, focusing on elbow down to the wrist and hand, does some shoulders, recently new to Everett Bone and Joint right there in downtown Everett, right off Pacific Avenue. And we're glad to have him today, and we're talking about dequivarians, and you pronounce it dequivarians or something like that. And this is overuse of two tendons coming down in the thumb. And we just talked about kind of the signs and symptoms one might have at home or at work. And then when you come in to see Dr. Mitchell, what's going to happen at that point in time?
Yeah, so I mean, it's important, like you said, to get a complete history and physical. There's just some other conditions that can overlap with deep Quervains, especially arthritis of the base of the thumb, or trigger thumb, which is a little bit of a different situation. A different tendon inflammation. So we kind of rule all those out, make sure that they're not kind of going on, and then essentially, if we're convinced that it's deep Quervains, we have a couple different treatment options. So if it's something that's really minor, only bothers you with certain activities, maybe like I said, maybe working out in your yard a lot, and it just kind of started, popped up, but it's kind of manageable, not super constant pain, all that kind of thing. Then we may start with just anti-inflammatories, kind of over the counter, Tylenol, Aleve, Advil, something like that. And then potentially a wrist brace. There's braces that can kind of shut down the wrist, even help the thumb a little bit, like a thumb spica brace you may have heard of.
Oh yeah.
It'd be kind of off the shelf, or we have them in clinic as well. Or just over the counter kind of thing, and just wear it for a few weeks, kind of see if that gets you through this acute exacerbation. If it's something that's going on for a few months, and this kind of more likely, when people get to me, because they usually go through their primary care doctor first, and so if they get to me, they generally be going on for a few months. They tried a brace, they've tried some, over-the-counter pills and things like that, and it's still just kind of bothering them. So then we usually recommend a steroid injection. And so what we do, take a little tiny bit of corticosteroid, and I mix it with some numbing medicine, some lidocaine, and we do an injection kind of right in the sheath, right in the groove where those tendons run. And that works maybe about 80% of the time. Like a single shot just takes care of it. It just calms down the inflammation, kind of breaks the cycle, if you will. And so that's typically what we start with.
And I mean, that usually is a pretty good treatment, and so you're always going to take the conservative approach. Now, tell me, is there a debridement surgery? If let's say you have someone that just doesn't respond to conservative care,
Sure.
And at that point in time, because I know as a surgeon, I know you're training, you're trained to approach every patient conservatively. Last thing you really want to do is do surgery if it's not necessary.
Absolutely,
but you get to that point where the patient's just quality of life is a problem.
Yeah,
they're not.
Absolutely.
I mean, what surgery are you doing?
So it's pretty simple. We actually call it a first dorsal compartment release, or de Quervain's release. We make a small little incision right over the wrist, and essentially what I'm doing is I'm just cutting through that tight ligament on top of the tendons. So they still sit in the groove, but if you cut that ligament, you just allow it to open up, then the tendons no longer rub across it as your thumb moves, and that is really, really high success rate for dealing with the pain. And it's a really quick procedure. You can do it under local only if you wanted to. Obviously, a lot of people like to have a little bit of sedation when they go into surgery, but it's a quick recovery. Like I said, it takes care of it the vast majority of the time. And you actually find a lot of the times, if you try the steroids and they don't work, when you go into surgery, you actually find these extra little compartments inside there. So there's actually a correlation with people that have these little extra sort of compartments where the tendons run, and people that sort of fail the steroids, and it's because the steroids aren't getting everywhere it needs to get. And
wow.
So, yeah.
That's so this is a decompression surgery. I mean, you talked about this.
Exactly.
These tendons are running in this tunnel. That tunnel has a sheath over it. You're going in the office, making a small incision, cutting that sheath, and you're just decompressing. You're just relieving the pressure inside that tunnel, which then takes that pressure off that tendon, decreases the pain. See how simple it is, Sophie? You see, we just did right there. Yeah, I got. You can do it. No, I'm just kidding. I got to tell our listeners. I've been doing this like 35 years. I'm a physical therapist myself. I'm blessed. Yeah. I am blessed here at IRG Physical and Hand Therapy to have some really, really good certified hand therapists. And our providers in the hand world, these are clinicians. A lot of them are OTs, some PTs, but these are clinicians that love the hand. And the hand is such a special area, elbow down. It's so detailed. It's so specialized. They take an exam, a CHT exam. They have to have like 3,000 or 4,000 hours of practical experience, and they sit for the exam. And like there's a 45% pass rate the first time around. And we're fortunate enough to have about 10 or 12 of them CHTs.
Oh my gosh, that's amazing.
Yeah. And like I said, I'm attention deficit hyperactive. I could never do that. The hand is give me a hip. I can work in the hip or the shoulder. sure. You get in the hand. And when I took anatomy in undergrad and then did anatomy dissection in grad school, and the hand is like, oh my gosh. I mean, it's just so it's overwhelming. It actually is overwhelming. Flexor pollicis longus, flexor pollicis brevis. And there's all these compartments. So, if you got some diagnostic stuff at your hands today, no pun intended, at your hands today, that is different than maybe 35 years ago. I mean, just the MRIs and the ultrasound and stuff. You can do a lot of your stuff in the office. These are office procedures and outpatients. Talk about the outpatient and office procedures now.
Absolutely. So at our facility, we do a lot of outpatient procedures. I mean, these days, a lot of orthopedic procedures are done outpatient. You don't really have to be admitted to the hospital anymore. We do a lot of, kind of local anesthesia or nerve blocks. Our anesthesia colleagues will do injections and even leave in catheters to allow for pain, continuous pain medicine. And, people do really, really well, I think, recovering at home rather than in the hospital. And so especially for the hand, it's very easy to put in some local anesthesia, numb up the area, and do a lot of these simple procedures under very, very sort of, either in office or just kind of little procedure room type of procedures. We don't necessarily need the anesthesia and the full operating room experience, but we can find this nice little middle ground, which is good.
Yeah. I mean, you love what you do, don't you? I can tell.
Oh, absolutely.
I can 100%. Tell you. Yeah. I can tell you love what you do. If a listener was going, wow, I've got these symptoms or I've got this hand problem, and I want to have someone like Dr. Mitchell. I'd love to have Dr. Mitchell look at this. How would our listeners get a hold of you? 1-800-CRISIS, or what is it? I mean,
absolutely. So we do have a clinic number. I have it right here if you want it, 425-339-2433. It's Proliance Surgeons, Everett Bone and Joint. You can make an appointment with me there, or you can go on the website. Again, Proliance Surgeons, Everett Bone and Joint. You can find us there, and you can make an appointment. I don't think you have to call anyone. I think you can just schedule with me there. And
that's just to kind of go over that. That's ebjproliancesurgeons.com. That's ebjproliancesurgeons.com. Proliance is Proliance. Proliance. I say it so fast. Sometimes people are saying are you saying Proliance? No, Proliance. Pretty cool stuff, man. I tell you, it's good to have you in the neighborhood, Dr. Mitchell.
Well, thank you. It's great to be here.
Yeah, I would love to have you back on. The hand is so complex. I'd love to have you back on talking about. Sure. You mentioned the base of the thumb. We hear a lot about thumb arthritis. We use our thumb so much throughout the years. If you're an active hitchhiker, you're going to use your thumb a lot. But we'd like to have you come on and talk about thumb arthritis and maybe some of the transplants or the arthroplasties that you're doing with the hand.
Sure. Absolutely.
Because like I said, when I first started in physical therapy, I remember seeing these rheumatoid hands, and they'd have the ulnar drift and the malalignment of the fingers and stuff like that. But in today's world, with some of the transplants and implants and some of the things that you can do, I mean, you can help those people. And
absolutely.
There's been
a lot of advances.
There's been some amazing advances. And there you go. If you want to get a hold of Dr. Wes Mitchell, fellowship trained hand surgeon, new addition to Everett Bone and Joint, right downtown Everett on Pacific Avenue. You can reach out at ebjproliancesurgeons.com or call 425-339-2433. That's the phone number. Don't sit out there with hand pain or dysfunction. Your hands are precious. Take care of them, okay? Make sure you wash them. Dr. Mitchell, thank you so much for your time. You did an awesome job.
You're welcome.
Yeah. Okay.
No, thank you.